Okay, well, we'll get started. Thank you guys all for being here. Again, I appreciate sticking it out through the end. I'm Sara Krzyzaniak. I am the program director at Stanford University, and here with my colleague Rob.
And I am Rob Cooney. I'm the director of faculty development at Geisinger Health in northeastern Pennsylvania.
So we're going to spend the next 20 minutes talking about learning theory. As a little bit of background, Rob and I have been talking about learning theory now for several years. We have a couple of different areas where we give this talk, and I will say from my personal perspective, as a medical educator, I found it really challenging as I started getting more involved with medical education to really understand how learning theory could be applied to what we're doing. I think I was actually a psych major, and so I knew what these theories were, but I really got tripped up with how do we apply it to what we're doing in medical education, which is really what spawned my interest in this. And I think our mutual interest is really taking that look at how can we be using education theory. So our objectives for today is just look at how we can use learning theory in medical education, look at how we can use these to guide our instructional design, and then implement some changes to common problems that we face using educational theory. And this QR code will actually take you to our handout. I don't think it's uploaded to the site, but we recognize this is 20 minutes. We're actually going to go fairly quickly, cover a lot of different theories, which is in some ways anti-learning theory, which is just to like slam you with a bunch of things all at once. We sort of nerd out about learning theory, so it's hard for us to just narrow down the list to what we'll talk about. So all of our slides and information, the important slides, will be on this handout for you as well.
So we're going to take a bit of a case-based approach that hopefully all of you will be able to identify with as we go along. And so our first case I'm going to pitch to Sara here is, whenever we give lectures, there's always some learners in the room who seem to start out really engaged, and then you can kind of see their eyes glaze over, and then they tune out. There are always those learners who are engaged the whole time and really seem to be kind of sucked into this material. And then there are those learners who are just kind of on their phone the whole time. Is there anything theory-wise that can inform how we can redesign our lectures that will help us kind of capture our learners' attention a little bit better?
So I think this is an excellent opportunity to talk about cognitive load theory. And there's some really great recent examples actually in the literature about how we can be using cognitive load as educators. As a quick review, working memory is where all of our inputs come in, but then that process of learning is how do we move things from working memory into long-term memory. Our working memory has a limited amount of space and processing capacity. Our long-term memory is unlimited. And one of the ways that we process information is by starting to chunk things or put things together into groups. And so as new information comes in, we reorganize it, we think about that new information in the context of past information that we have and start to move things into these schemas. But because our working memory has a limited capacity, we have to be careful that we don't overwhelm it as we're educating and teaching our learners. So cognitive load has three components to it. This might be review for you, but we'll go over the three components. Extraneous are the things that come sort of unrelated to that learning process or the information. It's the cold room, it's the sound of horns outside, it's distracting slide design. These are the things that aren't related to the content or your learners, but actually do take up part of the cognitive load and can impact how learning happens. Intrinsic cognitive load is really like how difficult is this task for that learner to do? How complex is this information relative to where your learner is? So a really complex task or complex topic is going to take up a lot more intrinsic space and not leave enough room for the others. And then finally, germane intrinsic load or germane load is that the work of learning, right? So it's moving things from working memory into long-term memory. How do we organize it? And this is sort of the act of learning and the work that goes into actually learning. So I want to take a look at these three examples, to your point, Rob, of where are our learners at. So this top example is what happens when we have a topic that is too complex for our learners. Assume that in any given moment, that extraneous load is going to be the same. I can't change the temperature in here. I can't change the construction outside. So that extraneous load is going to be the same. So in this top situation, the intrinsic load is too high for our learner. It's not leaving room for that process of learning to happen. They're going to spend that entire lecture just trying to keep up with you, trying to understand, and not have an opportunity to move that into their long-term memory. The second example there is what happens when you have a topic that is too simple. So if I ask all of you, if I give a lecture on how to tie your shoe, that's, for all of you in this room, I'm going to assume, who are great shoe tiers, that this isn't going to require a lot of processing for you to think about, to move from working memory to long-term memory, because you already have the schema. There's no action that has to happen for this to move into your long-term memory. So what we really want is this bottom example here, which is to say, again, we can't change our extraneous load, but we need to find the right amount of intrinsic load such that it's the amount of complexity that still allows space for that learning process to happen. So then we have to ask, how can we impact each of these three types of load? And there's a lot of literature out there on ways that we can impact this. I'm going to give an example for each, both in how we can decrease the extraneous load, manage the intrinsic load, and then optimize the germane load. So again, we talked about the extraneous load being sort of extra things. One is distracting slide design, and an example of this is split attention. And split attention is when there's two or more concepts that independently can't be understood without the other part. And if they're not visually or organized in a way that someone can look at them together, and I'm going to give you an example. So this image on your left is an example of split attention. You can't just look at that eye and know what A, B, and C are. You can't just look at the text and know where anatomically it's referring to. So you're jumping back and forth between A and the text and trying to go back up and seeing what that looks like. So the example on the right is how we could manage that extraneous load to bring it all there so you're just looking at one space. This happens a lot too when people print slides, but there's things on there that make no sense without having it also someplace else. One way that we can manage that intrinsic load is to break things down into more simple, isolated elements. This might invoke some PTSD for people looking at this graph, but you can imagine if we give this to a first-year, student or even intern, this actually might, they will look at this and be immediately overwhelmed. So what we really need to start with is, what is acidosis? What is alkalosis? And only once we start to put together all of these different pieces can we give them this flow chart to help them understand. And then finally, optimizing germane load is how do we help our learners process information? Again, how do we help them move that information into new schemas? So one way that we can do this is with interleaving. One example is teaching about arrhythmias. You might have a lecture on tachydysrhythmias. You talk about what is SVT, what is polymorphic VT, what is AFib RVR. You review each of those. But then, in your next session, you give a pile of EKGs, all with the tachydysrhythmia, but not necessarily all the SVTs or all the polymorphic VTs. So in this case, they already have that content knowledge, but as they then start to look at these EKGs, they're going to pull from that previous information in a way that isn't all chunked and ordered, and they're going to start to work what they're learning in those EKGs into the schemas that they've already fit. So instead of just doing all your SVT, doing the lecture and then just looking at SVT EKGs, and then the next day moving on to VTAC and only looking at VTAC EKGs, interleave it and weave it in together. So with that, I'm going to actually let Rob talk to you a little bit more about what we can do for our instructional design. I think as we all have transitioned to a virtual model, we're using a lot of Zoom. We've always been heavily reliant on PowerPoint, but I'd love to hear how we can manage some of the content on our slides. I'll let you advance there, to help this.
Wonderful. So both cognitive load theory and multimedia learning theory are what we consider cognitivist learning theories. So they have to do with how the mind processes information. Multimedia learning theory also depends on that multi-stage model of memory that we just talked about. But in this particular case, we're going to focus just on visual and auditory input. Multimedia learning theory posits that there's what we call dual channels that we're processing information through. First, you have kind of your pictorial model. When you look at an image, your eyes see it, it goes into your working memory, where it compares that image with things that are in your long-term memory. So if you see a cat crossing the street, your long-term memory will give you every image of a cat, and you'll say, yes, that's a cat and not a dog, right? We don't think about any of this stuff, but it just happens naturally. When we're reading words, though, it goes a little bit differently. So if we read a word on a slide, we see it with our eyes, it goes into our working memory, but instead of seeing an image of a word in our long-term memory, we know that it goes through this verbal model instead. So your long-term memory actually converts it into language and brings that back out, which isn't a big deal, except when you're hearing words at the same time. So when you're listening to a person talking and they're speaking words, that channel can get congested. So you can't read and listen very well at the same time. And the problem is we can read much faster than most people speak. The average human reads at about 200 words per minute, and we only speak at about 100 words per minute. So which do you think gets the priority? It's the written words. So that's why when you have very text-laden slides, your audience is actually going to be reading them and not really paying attention to you. So this is a fairly typical slide in emergency medicine, right? And we're going to go through some principles of multimedia learning theory, and we're going to change this into a much better slide. So first off, it's not too bad, right? It's not overly text-laden. We have an image that's relevant to the procedure, right? But what am I really asking the audience to remember from this slide? The tools, exactly. I want them to remember the tools they need to do a perimortem hysterotomy. So again, the first principle is that the multimedia principle, pictures and words are better than either alone. This looks okay, but it's the wrong picture, right? This is the picture of the procedure, not of the tools. So we're going to replace the image with the more appropriate one of the tools. Coherence has to do with taking out irrelevant words or irrelevant images. I like to say this is the don't put pictures of my kids principle into the slides. So be very careful using cat pictures and kid pictures because they're irrelevant and they actually distract from learners' ability to put things into their long-term memory. They'll remember your family vacation more than the content you want them to. So in this particular slide, we're talking about the needed tools. We're going to get rid of the nice-to-haves because you don't really need them. Contiguity has to do with putting things together in time and space. So you can use animations to make words appear as you speak about them, but you really want those words to appear where they belong on the slide. So very similar to the image that we saw in cognitive load, we're going to move things over so that they actually go with the tools. Signaling has to do with the changes you can make in the text to really draw the learner's eyes to that particular principle. You can use color, you can use font size, all of those are fair game here. So again, like that. And then redundancy is the don't read your slides principle. So you want to make these as simple as possible, but no simpler. And we pretty much had already done that in the previous slide. But this is what my final slide would look like in this particular lecture. So I'm going to be teaching the learners about perimortem hysterotomy, and I'm going to take it step by step. And the tools that you need are going to be the scalpel, the scissors, and the clamp, and nothing more. If you have those three, you can perform the procedure. And I intentionally chose my background to look like a surgical towel because that's likely how things are going to be presented when they're actually in the clinical realm right next to them. So we're going to shift gears a little bit now. We've talked a lot about kind of classroom teaching stuff, but what we want to focus on now is how do we actually teach a learner to master a procedure? We all have to do procedures, and a lot of times it's quite variable in the learner's ability to actually be able to perform them. So Sarah, what theory can guide our application of learning about procedures?
All right, so there are two theories that we'll talk about, especially as it pertains to teaching our learners how to do procedures. So the first is mastery learning. I think we can all reflect on a time, if intern orientation is coming up, as part of our intern orientation, you put in an hour of central line training and just expect, you might give them some content beforehand, watch this New England Journal video, review the steps, here's some readings. Everyone's going to come for this hour on Wednesday. We're just going to learn central lines, and at the end of this hour, you're going to be done. Mastery learning says that actually what we should be doing is providing this content, but letting each learner take the amount of time, however much time they need to become a master or an expert or proficient in this. Sort of like CBME, right? The shift that we're seeing towards moving away from time-based learning and instead saying we just need to make sure that you are competent at the end of this training period. So So mastery learning involves a few discrete parts. There's a cycle involved in this. There's a pretest to see where your learners are at. Again, if we go back to our shoe tying example, if I gave you all a pretest, I suspect all of you would pass, and you would just actually bypass all of this down to pass and you would move on. We wouldn't need to do a lot of instruction around it. Most of the time, though, as we're teaching more complex procedures, there's going to be parts that they miss. So then we enter into the mastery learning cycle. We do teaching or coaching around the parts that are missed, ensure that there's understanding, and then take our learners through that test again. After that test, there's the two options. You either pass because you've done all of the steps in the right order, or you don't get all of the steps and we start over again with that coaching. And this cycle repeats itself until our learners have demonstrated competency. Barsick out of Northwestern has done a lot of this work around central line teaching and has shown that using mastery learning for central line procedures can decrease infection rates. And so now it's used a lot. And it's used quite a bit with simulation-based teaching as well. And then along those same lines is Erickson's theory of deliberate practice. So this gets to this idea that experts are not born, right? Someone isn't born a great central line proceduralist, but only through deliberate practice do we become experts in something. And it's not just automated, mindless practice. It's this process that we go through to make sure that we're being deliberate and thoughtful about the practice that we're doing. So the components of deliberate practice are, first of all, that you have to have a strong curriculum. You have to know exactly what are you hoping your learners to achieve at the end of it. You have to have frequent, constant repetition. Again, you don't go one time and intern year to practice central lines and then never do it again. There has to be a continuous feedback loop. So this is two parts. This is the learner has to be able to reflect on their performance, and there has to be a coach involved as well. You need someone to be supervising the learner to provide this feedback, to let them know how they are doing, which they can then reflect upon and change the practice that they're doing. This kind of practice is mentally demanding. So this isn't just the go in and hang out with friends and while you're talking about the latest Bachelor episode that you're just doing central line. But this requires a lot of thought, and it requires you to be engaged in the material. And it's not always fun. So this isn't the type of practice that is, you leave energized and invigorated. This can actually be really hard. But all of these components go into this deliberate practice model. Okay. And I know we're running a little bit short on time, but as a program director, I have to ask you, Rob, and I know you are a program director as well, I do have a hard time sometimes getting my learners to be motivated to do things. And, we can use the example of research. We have to have a research project. My chair really wants more research to be done, but I'm having a hard time getting my residents to get behind that. Curious if you have any ideas.
So show of hands, who here has ever had a lazy resident? Right? So let's talk about motivation, right? There are several theories of motivation in the med-ed literature now, but one of our favorites is the idea of self-determination theory, which has to do with moving a learner from extrinsic motivation, i.e. the carrots and sticks that we all give them, to intrinsic motivation, the idea that they're going to engage with the work for the personal meaning they get from it. And there's actually, you can have a motivation, which isn't even on this yet, so they have no motivation. But, so Ryan and Deci came up with this idea of self-determination theory, and it has three major components. The idea of competence, autonomy, and relatedness. Competence has to deal with the idea of mastery, the feeling that I am able to perform something and to do something well on my own. Autonomy is that I have a choice in what I'm going to do. And finally, relatedness is a feeling of belonging, that I'm part of a community outside of myself. If you can trigger these feelings within your learners, then you can move from the extrinsic motivation to intrinsic motivation, or so the theory goes. So how do we do some of this? Well, the relatedness is actually one of the easier things, right? Just by being a member of a community in a residency, as long as you have a good culture, they're going to feel some relatedness from that. The autonomy has to do with giving them choices. So sometimes we don't allow our residents to have enough autonomy in their practice, and the literature shows over and over that they feel that they deserve more autonomy than they get. So how can we take a step back and have a discussion with them about the autonomy? In the case of research that we were just discussing, that's a little bit easier, right? We can give them some options, or we can support them into exploring something that they want to explore on their own. And the competence is probably the harder part to build here, because as their teachers and coaches, we do try to support them, but they're going to stumble, they're going to fail. And so how can we work with them to reframe that failure into competence? And again, it's a lot of a coaching relationship that we have with them. Another thing that we can rely upon is this idea of communities of practice. So communities of practice is one of the kind of hot topics in medical education more recently. A community of practice is a group of individuals that learn together to address a common issue or concern that they have together. If you have a group of people who's just meeting without a kind of a shared purpose and something they're working on, it's just a group of friends, right? It's not a community. But when it comes to research, all of you probably have some researchers within your own institution that have niche interests. And so how do we get the residents to be involved as members of that type of community? One, just invite them along for some of the meetings. In any community, the first step is to become a fly on the wall, what we call legitimate peripheral participation. It's a person that's sitting on the outside of the circle, but listening into the conversations. It gives them the chance to say, yes, this is something that I have an interest for, and if they don't, they can walk away. You give them that autonomy again. But if they are interested, then they can come into the circle and become part of the core group that practices together to work on a particular topic. So that brings us to the end of our rapid fire learning theory in 20 minutes. Usually we give this talk over 1 to 3 hours, so you kind of got the rapid fire. We do want to put a plug in for the Learning Theory Made Practical series that's available for free. It's now up to 5 volumes, all written by the faculty members from the Faculty Incubator Project, started 5 years ago. And again, you can get them free at that link, or we also have the link in our handout that we gave earlier. So thank you all for being a great audience, sticking it out on the very last day of the very last hour. And I'll be happy to take a couple questions.